Hi guys, so this is going to be part one of the cardiac rhythm interpretation course that I've been teaching within the hospital. So now it's going to be on video and I'm breaking it down into 5 different parts. So our part one is going to be just the basics and background. So let's just do a little bit of anatomy and physiology review. So here you can see the anatomy of the heart and the flow of the blood through the entire system, right? So we've got our superior vena cava, our inferior vena cava, both dump into the right atrium, move through our tricuspid valve into our right ventricle, move out through our pulmonary valve into the pulmonary artery, go to the lungs. From the lungs, they come back to the heart via the pulmonary vein to the left atrium, go through the mitral valve to the left ventricle, and get pushed out through the aorta, through the aortic valve into the rest of the body. Right? So just kind of like the generalized run through of how blood itself flows. Now, what about the electricity? So the heart has an electrical system that stimulates the heart to contract in an orderly fashion. The heart cannot pump without this electrical system, right? However, just because there is electrical activity doesn't mean that there's mechanical activity. We'll talk more about that later, but just realize there has to be an electrical system in place in order for the heart to beat. An electrical impulse is going to travel from the SA node, so that sinoatrial node, located in the right atrium, through the walls of the atria and cause them to contract. So to cause the right and the left atrium to contract. That impulse then moves down through the AV node. Here's the AV node located between the atria and the ventricles. And then it travels down through the bundle branches to the Purkinje fibers located in the ventricles. Now the Purkinje fibers conduct the impulse from the apex of the heart up the ventricular myocardium, and then the ventricles contract. So pacemaker cells are the specialized cells that initiate and conduct or transmit those electrical impulses. And those cells are found in the SA node, the AV node, and the Purkinje fibers. So each of these groups of pacemaker cells has an intrinsic rate. They can each initiate and pace the heart, but they each have a different range of heart rates. So the SA node, that's the heart's normal pacemaker. It's located in the right atrium. The normal heart rate from this node is about 60 to 100 beats per minute. The AV node is in the AV junction. So that's the atrioventricular junction where the atria and the ventricles meet. If the SA node fails or it slows down too slow, the AV node can actually start to generate an impulse. Now, the AV node has an average rate of about 40 to 60 beats per minute. Now, finally, we have our Purkinje fibers, which are in our ventricles, and they can generate an impulse if both the SA node and the AV node fails. And this has an average rate of about 20 to 40 beats per minute. This is going to be important later when we start to identify the different rhythms. So we really want to remember these 3 different sets of numbers. SA node has an intrinsic rate of 60 to 100, AV node about 40 to 60, and ventricles about 20 to 40. Lead placement. Now this is something, it's just kind of a quick review. Most people are pretty comfortable with this, but we typically have these 5 different cables that we're going to be attaching, right? And so we've got our RA, so our right arm, if you will. Now that is goes on the upper right portion of the chest. So if you think white is right, remember that one. And then we've got smoke over fire. So the black LA node is going to go above the red LL. And then we've got this brown in the middle here, right to the side of the sternum, because we just don't want to ever put electrodes over bony prominences because they just don't read as well. And then we have that right leg, the green. Now, so you've got white is right, smoke over fire, and people kind of forget this one. I used to say it was always poo on grass to remember that the brown was above and the green was below. But people have other funny ways of remembering. So that's really your basic lead placement. We're not talking 12 lead, that's very specific lead placement. This is just kind of a generalized lead placement. All right, so waves and intervals. These are super important to understand in order to actually identify an EKG rhythm. So let's break it down. There are 5 complex waves that we need to assess when we look at any rhythm. P, Q, R, S, and T. Now the P wave is the first wave of the EKG complex. You can see it right here. You can see it right here. When it's normal, it's small, rounded, and represents the conduction through the atria. So that atrial depolarization. Normal P waves indicate that your SA node is functioning. Now, the Q, R, and S waves are often referred to altogether as the QRS complex. This represents the electrical impulse moving through the ventricles and causing ventricular depolarization. Now, a narrow QRS complex indicates that the electrical stimulus is coming from above the level of the ventricles. You can see here's your QRS complex, and here's your QRS complex. The T wave is the asymmetrical rounded and comes after the S wave. All right, so we can see that here. We see that here. Now that represents repolarization or relaxation of the heart. Now this is the vulnerable time of the heart, because if the heart attempts to depolarize during this resting phase, it can lead to erratic rhythms such as VFib. And we're going to talk about that later. And you can see here, I really like this image because it kind of shows you what's happening with each of the waves. So you can see this P wave, this hump, that's the impulse traveling from the right to the left atria and causing the two to depolarize together. And then the impulse moves down, gets the QRS complex, that's the ventricles actively depolarizing. And then your T wave here is the ventricles actively relaxing. This is not actively relaxing, they're passively relaxing. They're relaxing. It's probably a better way to put it. Okay, so if we talked about waveforms, then we want to talk about intervals. So intervals are the distance measured in time between two cardiac waves. So the PR interval is the time that it takes for the electrical impulse to travel from the SA node to the AV node. The AV node is the gatekeeper for all impulses traveling from the atria to the ventricles. The electrical impulses are delayed at the AV node before they're allowed to travel to the ventricles. And that's measured from the beginning of the P waves, beginning of the R waves. So this PR interval here, it's the impulse is sent from the SA node, travels through the atria, causes them to be polarized, travels down to the AV node. And then here is when the AV node spreads that to the ventricles. All right, so this is kind of that time that it's holding in the AV node. The QRS interval is the total time it takes for the electrical impulse to move through the ventricles and cause depolarization, so that contraction. It's measured from the beginning of the Q wave until the end of the S wave. And the general rule of thumb is that a narrow QRS complex tends to mean that the impulse originated from somewhere in the atria, somewhere above the level of the ventricles. The wider the QRS complex, the lower the impulse originated. Now the QT interval is the time it takes for the ventricles to depolarize, so contract, and repolarize, relax. Its value varies with the heart rate. There is a formula to use to apply the QT interval to the heart rate, so it'll give you what's called a QTC, and that's the correct QT interval based off of the heart rate. And that can be a little bit confusing, but essentially what it means is that your heart rate's really fast, your QT interval would be shorter, right? If your heart rate's really slow, your QT interval might be longer. So by getting a corrected QT, so a QTC, it tells you really more about the relationship of that interval rather than the actual number. How do we measure all of this? So put it on paper, the electrical conduction that occurs in 1B is displayed on grids such as this, right? And that's what we're used to seeing as EKG paper. The small square is 0.04 seconds of time. A large square is defined by the dark lines and contains 5 small squares high and 5 small squares long, and equals 0.20 seconds of time, which should make sense because 0.04 times 5 is 0.2. All right, so what's considered normal? So we have a PR interval, normal is 0.12 to 0.2 seconds, so typically less than one of those large boxes. QRS interval norm is 0.08 to 0.12 seconds, which is about 2 to 3 small boxes. And the QT interval is typically less than 0.4 seconds, but again, we would want to calculate a QTC to see if the relationship is appropriate for that situation and not necessarily just the number. All of the other ones, though, the numbers are very important. And that's why we're not going to talk about QT intervals anymore moving forward, because that kind of starts to go into a different category of what we're focusing on. So what we really want to focus on is the actual rhythm interpretation, and that's going to be focused on your PR interval, your QRS interval, and then those waveforms. So there's 5 steps to rhythm interpretation that can help you. If you look at an EKG monitor and you say, I'm not really entirely sure what that is, you use these 5 steps and it'll kind of help to narrow down your differentials and figure out what's actually in front of you. So the first thing you want to do is assess if it's a regular or an irregular rhythm. So look and see if the R to R interval, so one R wave to another R wave, and that's what you can see with these red arrows, is regularly spaced. If it is regularly and consistently evenly spaced, then the rhythm is regular. If it is not regularly spaced, then look to see if it is occasionally irregular, meaning only one beat doesn't fit the pattern, regularly irregular, say the third beat is always the one that's different, or irregularly irregular, no pattern can be found. You can also just break it down and simplify it and just say, is it regular or is it irregular? Step 2, assessing the rate. There are several ways to manually calculate rates. The first method, and arguably the easiest, but not always the most accurate, is to take a 6-second strip and count how many QRS complexes you see. Multiply that number by 10 to get a rough estimate of the heart rate. And that's what you see with this image on the left. A second method is the large box. For each large box, there's a corresponding heart rate that you would need to memorize. 1 large square equals 300, 2 is 150, 3 is 100, 4 is 75, and 5 is 60. That's what you're seeing on that image to the right. Now, the smaller boxes left over represent increments of 5 beats. So using the image on the right here of this screen, you can see that there's 3 large boxes between the 2 R to R waves, followed by roughly 3 small boxes. So the ventricular rate of this rhythm is about 85. So you've got 100 minus 1, 2, 3 boxes, which is minus 15. So we get about 85. So you can see it's a little bit more specific than if we were to count and multiply by 10, because then we'd probably get either 80 or 90. A third method is to divide 1500 by the number of small squares between 2 R waves. In the same example above, we can see that there, if we count them out, there's 18 small squares between these 2 R waves. So we would take 1500 divided by 18 and get about 84 beats a minute. Now, the second and third methods, so the counting boxes, can only be accurately utilized on patients with regular rhythms. So their R to R interval is regular, not irregular. And so you can be limited with using this system if your patient has an irregular rhythm. So why I think it's the easiest, even though it's not always been most accurate, to use the 6-second strip method and multiply by 10. Step 3, assessing P waves and the QRS complexes and their relationship. So we want to look at the P waves, and I have all of the P waves circled in red here. Does every P wave have a QRS complex behind it? And does every QRS complex, which is highlighted with the green arrow, does every QRS complex have a P wave in front of it? Do all of the P waves look the same? Does their relationship change with the QRS complex through the strip, or does it remain the same? So this step is really all about assessing that relationship between P waves and QRS complexes. Step 4 is assessing the PR interval. So look at the start of your P wave and see how long it takes to get to that R wave. Is it normal? So less than 1 large box, so less than 0.2 seconds is considered normal. Is it longer than 1 large box, or 5 small boxes? Is the PR interval consistent with every beat, or does it vary with beats? And if it varies, can you see a pattern to that variation? Step 4 is really just that PR interval, wanting to know everything about the PR interval. Step 5, assessing our QRS complex. So here we want to know, do we have a narrow QRS complex, less than 0.08 to 0.1, aka about 1 to 2 small boxes, or is it wider than that? Okay, a couple of things to remember. We want to always look at the patient and treat the patient. And if you can't remember all the rhythms that we're going to discuss in the next 4 videos, or where the electrical stimulation is coming from, that's okay. You can identify if the ventricular rate is too fast, which is preventing perfusion, too slow, which is preventing perfusion, or too unorganized, which is preventing perfusion. All right. If you can figure that out, then you do your quick assessment, skin color, pulses, respiratory rate, blood pressure if you're able to, and call for help and just follow your ABCs. But if you can identify those pieces that the perfusion is being compromised, whether it's too fast, too slow, or too unorganized, then that's huge. And that's really what the goal of all of this is. All right, so stay tuned. The next video is going to be all about atrial rhythms.